Hello, and welcome to the Secours Richmond Community Education Awareness Program focusing on neuroscience. I'm Pat Lane, the Neuroscience Administrative Director for Secours Richmond, and I'm very pleased to be here with you tonight. We started our series 3 weeks ago on World Stroke Day, and we talked about various issues at that time. We talked about strokes and how every 4 minutes someone dies from a stroke, and we talked about every 40 seconds how someone has it within the United States. Well, tonight we're here to talk about how stroke is preventable, how it's treatable, and how it's beatable. We have a very special panel tonight, and we'll be introducing them in a few. We're going to talk about how it's preventable, and so we're going to be talking with Dr. Gaughen, we're going to go into some of his intro in a few. We also have Brenda Sawyer here with us as well. She's a nurse practitioner. We have Matt Wilks and Alison Clarke, who are also here with us from Sheltering Arms. We're going to discuss what resources there are available for you, and we're going to talk about the continuum of care and how that support of stroke, if you were to have one, it's a journey, and you should always continue to strive to have better health. This evening, I'm going to introduce our guest now. We have Dr. Gaughen, and Gaughen is a neurointerventional specialist, and he specializes in radiology, and he also specializes in that diagnostic radiology. He did his fellowship at UVA, and he is board certified as a diagnostic radiology by the American Board of Radiology with a certificate in advanced qualification in diagnostic neuroradiology. He is definitely going to explain that role to us tonight and how that links into stroke and the treatment. He's a member of the American College of Radiology and the Radiology Society of North America, the American Medical Association, and the American Society of Neuroradiology. Our next panelist is Brenda Sawyer. Brenda Sawyer attended the University of Houston, and she got her finance degree there. And I like to say, since I'm a fellow nurse, that's when she went back and decided that she was doing the right thing and got back and got her master's into nursing. And so she's a nurse practitioner. She works for the Secours Neurointerventional Surgery Services Clinic at St. Mary's Hospital. And we're going to talk to Brenda tonight about being a nurse practitioner and what that means. We're very pleased to also have with us Matt Wilks. He's joining us from Sheltering Arms, and also Alison Clarke. They're going to talk to us about the future of rehab and the role of technology in rehab. Now, Matt got his degree from the Medical College of Virginia in Richmond, and he has his master's in physical therapy. He also went to the College of William and Mary, and he received a master's in biology. So I have a biology degree as well. So we learned things here tonight. He also did a minor in psychology, which I think definitely is needed with our neuro population. He's done multiple presentations, and he's going to share some of that knowledge on us tonight when he talks about achieving superior outcomes, talking about using novel, evidence-based, and clinical practice guidelines. Closing out our team tonight is Alison Clarke, again from Sheltering Arms. Alison is a certified therapeutic recreation specialist. She received her undergraduate degree in recreational therapy with a certificate in gerontology. And we're going to have her explain what that recreational therapy truly means. And she got that from West Virginia University. Alison is in the Community Recreation Services Director of Sheltering Arms, which is very close to here to the Comcast station. She's also certified in chronic diseases and is a self-management instructor. And she is going to talk to us about stroke and being out in the community and talking about it through the lifestyle and progression. Welcome, everybody. So So callers, we're going to take your questions between 6:30 and 6:45, and the number to call is 804-915-5212, and I'll announce that throughout the series. So tonight, we're talking about stroke, how it is preventable, beatable, and treatable. And I wanted to have all these guests on because, you know, people think when you have a stroke, it's over and that it's doom and gloom. And so I brought the happy folks on tonight, and hopefully that personality then will come out tonight to let you know that we have some pearls of wisdom to help you to prevent it. And then if you do have a stroke, something to treat it. And then the journey continues on the continuum of care with rehab. So let's start off, you guys, talking about prevention. And I'm going to start with Alison. And I want each one of you to share your perspectives and give us one thing that you can share with the audience. And they said, we really want to prevent from having a stroke. And I'll start off, you know, this month and right now we're in the window for insurance, particularly for those who do not have insurance with the Affordable Care Act, and talking about insurance coverage. So the one thing that I would say to folks is you need to have a baseline and a medical assessment. So I'm going to stick on that tonight as my theme, being with the medical assessment. And I'm now going to let Alison start and tell her what she would say if somebody says, well, how can I just prevent stroke? What is something I should do?
I would say the most important thing is to really maintain a healthy lifestyle, and a big part of that is, of course, physical exercise on a regular basis, as well as recreational social activities that really impact your quality of life. We all know that exercise helps prevent chronic diseases, which it could eventually lead to stroke. So staying active over your lifespan and figuring out how you can adjust those activities to meet your physical level at the time is important for stroke prevention. And
that's good. So Alison's going to keep on her theme as well. We heard that she used recreational therapy. So as we talk about preventable, treatable, and beatable, I'm sure she'll share those recreational things that you can do in each one of those stages. Matt, what would you say would be an answer if somebody asked you about prevention?
Yeah, to add what Alison just mentioned, a healthy lifestyle is comprised of exercise and then nutrition as well. So learning how to eat well, developing habits that honestly you can live with. There's a lot of things that we all know would be good for us, but maybe we can't make those habits, we can't fit those into our lifestyles. So it's about making small changes in the beginning, seeing some initial positive results, and then building on that, finding something you can live with over the long haul.
Great. And we talk about nutrition. So one of the things that I would say, there are a lot of resources out there about nutrition. And we certainly at Secours have some things that you can go to our website to see, American Heart Association, I'm sure Sheltering Arms as well, you know, and also in the grocery stores and even in the drugstores now, you can talk to folks about what is some good nutrition labels are. If you go into the store, you can also see the little hearts that are on some of the boxes to tell you whether it's heart healthy. So nutrition is key. And nutrition is key also when you're treating, because your body needs to get certain nutrients to heal. Brenda, nurse practitioner, I'm sure you can share some tips on prevention.
Yes, I think probably the biggest thing, just to kind of tie it into what everybody else is saying, is to people be aware of what their blood pressure is. We've done many studies that have said that keeping your blood pressure within certain parameters lowers your risk for having a stroke, and certainly when you possibly have had an aneurysm, that can certainly cause a possible rupture. So there's many things that contribute to that. Obviously nutrition, exercise, and that's so to speak.
So audience in the RVA, you're hearing some themes: recreation, nutrition. Brenda brought up about hypertension. That's huge when you're talking about stroke. She also brought up a different type that I'm going to put Dr. Gaughen on the spot on later to really explain what is an aneurysm and what does that mean? Is that a stroke? But we'll save you for that for later. So what I would like to ask you, what would you like to close out this session with when we talk about prevention?
Well, Pat, excuse me, Pat. First of all, I'd like to say that I'm very excited to talk about that later. It's a pleasure and an honor to be here speaking with you. I'd like to say hello to my little 5-year-old daughter, Savannah, who's celebrating her 5th birthday today. Hello, Savannah. Sorry I'm missing it. And I think everybody on the panel here has brought up a very strong point, but I think bringing all of that together, I think it's important to realize that first, we do need to be under the care of physicians. You do need to seek medical attention. A lot of the things that are preventable stroke risk factors are things that we don't necessarily feel on a day-to-day basis. High blood pressure is a silent assassin. High blood sugar or diabetes is a silent assassin. So monitoring these things before you develop symptoms from them is very important. But I think overall, I think the idea of owning your own health is a very important concept in preventing stroke. So we know there are several risk factors that contribute to the risk of developing stroke, such as high blood pressure, high blood sugar or diabetes, obesity, poor exercise, high cholesterol, smoking. These are all things that we have the ability to affect in our day-to-day lives to help prevent stroke. And I think taking ownership of your own health and doing the things that you can do to minimize those risks are going to go a long way to keeping you out of my office, which is good for you, maybe not so good for me because I've got kids to feed. But I think that from a preventative standpoint is the most important thing that an individual can do to keep themselves out of the hospital with a stroke.
So thanks, Dr. Gaughen talked about things that what we say is modified, or things that you have the ability to change. So he talked about knowing your numbers, cholesterol, diabetes, definitely about no smoking. That's one thing that I will say that can be very much something that you can stop and we can help you with. Again, if you go on the website, we will have some ways that can be able to help you with that. So we've talked about prevention, and we've given you a few tips, just quick tips with the first few minutes. We now want to shift in talking about treatment. And I would certainly not want to shift without saying, before you know whether you need treatment, you certainly need to know the signs and symptoms of stroke. So we would want you to act fast, we want you to move fast, and we want you to know fast. So what we mean by that, when I say fast, we use that word to help you to remember some of the major signs and symptoms of stroke. So F stands for face, that your face may be drooping or your you may not have symmetry or one side does not look like the other. When you look at A stands for arm weakness, or you may drift, one of your arms is drifting normally, you can't control it. S stands for speech. It may be slurred or you don't understand what you're saying. It's really garbled. It's not like what you normally sound like. And then T is critical, the time of last known well, and I always say also time to call 911. So that's a brief description. And now we're going to go back to having the panel talk about some of their expertise to be able to help us with the treatment segment. So Dr. Gaughen, back to you. Thanks for being here with us today. Can you give us a brief description of the types of strokes that they are? And then with the types of strokes that they are, what actions would you say somebody should take right away?
Absolutely, Pat. So there are 3 main types of stroke. And before we get into that, I think it's important to recognize that any stroke can look the exact same, no matter what type of stroke it is. So as Pat just illustrated, if you have things that seem like strokes to you, if you feel weakness or numbness on the side of your body, if you are having difficulty with speech, you need to go to the emergency room immediately. One of the biggest things that I hear people say is, I had weakness on the left side of my body and I thought I just needed to take a nap. Heart attack, we've done a very good job of educating the public on heart attacks. You have chest pain, you go to the emergency room, you get worked up. Stroke is a much more complex disease. The symptoms can be very different from patient to patient, and it's very important that you have a very high level of suspicion when you start to develop these symptoms that you be seen by medical specialists. And that's because there are several different types of strokes, and they all have very different treatments and very different time windows for which treatment is effective. So to dive into that a little bit, we have 3 basic types of stroke. We have what we all think of as stroke, which is ischemic stroke, which is a blockage of a blood vessel that causes lack of oxygen to a part of the brain that causes that brain to die. That's about 80% of strokes that we see are ischemic strokes. Another smaller subset of strokes are what we call hemorrhagic strokes, which is technically bleeding into the brain. And then we have a third set of stroke, which is what we call stroke mimickers, and those are people that develop neurological problems as a result of things like tumors or seizures or other disorders that don't necessarily relate to the blood vessels. So the first thing that we need to do when a neurological symptom comes up is to figure out which of these stroke pathways we are dealing with, because each one of those has a very different treatment algorithm.
And so, you know, what you went to school for, and I wanted to talk about this, there's something that we will do as healthcare practitioners to figure out what kind of stroke that is?
Absolutely, Pat. I'm glad you asked that question. So, as a patient, as a person in the community, your job is to identify yourself as having a stroke, or the person sitting next to you on the sofa watching this cable TV as having a stroke, and come to the emergency room immediately. And as an interventionalist, we have, as a stroke doctor, we have medications that we can treat various types of strokes. As an interventionalist, we also have different other treatments that we can do to treat stroke besides medications. And as a radiologist, we have several imaging studies or diagnostic tests that we can perform when you come in to determine which type of stroke you may be having and what your treatment options are. So, with ischemic stroke, which is what we think of as stroke, there is a pretty tight time window in which we have the ability to potentially stop or reverse the stroke. And that's what we talk about as time is brain. And time really is brain. We lose between 1 and 2 million neurons or brain cells every minute. So the longer we wait to treat you, the more the damage is going to be. So no matter what treatment we have to offer, it's uniformly better the quicker we get that into place. And so we have very well-oiled treatment algorithms in the hospital once you come to our attention to be able to be placed into one of those treatment algorithms and be treated as quickly as possible. The first thing that will happen to you in the emergency room when you're seen with stroke symptoms is to be identified as someone who's having stroke symptoms and to be seen immediately by a medical professional who will assess you and figure out if you are indeed having stroke symptoms. If you are, probably the second test that you will have done after you have blood work drawn and this examination by the doctor is to be taken directly to a CAT scanner or CT scanner, which is a non-invasive test that takes a picture of the brain that does a very good job of telling whether someone is having a stroke from blockage of a blood vessel, stroke from blockage or bleeding from a blood vessel, or one of these other stroke mimickers like a tumor. Once we've got that CAT scan, which just takes about 10 seconds to get, we are able to look at those pictures and make a very informed decision about what the next step in that treatment is.
So let me just reflect. For the ischemic, you talked about the clot buster. So if I have an ischemic stroke and I want to be treated, can I wait, or will that be done within 24 hours, or is there a certain time that
Such good
we have to
questions,
do those
Pat.
types of things?
Such good questions. So of all of these types of strokes that we're talking about, the one that is the most time sensitive and incidentally the one that is the most common cause of stroke symptoms is ischemic stroke. And that's blockage of a blood vessel that causes damage to brain. Now the brain lives on oxygen. It can only live without oxygen for a very short period of time. What happens with ischemic stroke is either clot develops in the blood vessels of the neck or brain, or from the heart, clots form and migrate or flow to the blood vessels of the brain. Once that blood vessel gets blocked, then oxygen stops getting to that part of the brain, and we have a very short period of time to get that blood vessel unblocked before permanent damage is obtained. So get this information quickly. With ischemic stroke, we have a medication that we can give through the veins, through the IV, which is a medicine that we call a clot buster or a thrombolytic agent. And what it does, and its name is TPA, or tissue plasminogen activator. And it's a medication that we inject into the arm or into the leg, wherever we have an IV, and it circulates through the blood, finds that blood clot, and is able to dissolve it. And it doesn't work 100% of the time, but it is the most effective drug that we have to stop ischemic stroke. We have very large amounts of data, literature, that supports that it can be effective up to 4.5 hours after someone develops stroke symptoms. Certainly, with that being said, the sooner you get that medication, the more likely it is to be effective. You are uniformly going to do better if you get that clot buster medicine 10 minutes after you have a stroke, as opposed to if you get it 4.5 hours after. So recognizing that you have a stroke and getting to the hospital as quickly as possible is very important. And once we make that decision, we work very quickly to figure out whether or not you are a candidate for that clot buster and want to get it to you as quickly as possible. So if you can make it in that window, that is the most effective treatment that we have. But there are a lot of people who aren't able to make it in that very short time window. And as our technologies get better, we have been able to broaden the amount of people that we're able to help that fall outside of that window, or people who don't meet the criteria for getting the clot buster medicine. Some people's blood is already too thin. They've had bleeds into their stomach or into their bowel. They've had surgery recently, strokes recently, heart attacks recently. Those all keep us from being able to give that drug. So we now have the ability to do some other things that can also help. And as an interventional radiologist, as an interventional neuroradiologist, or a neurointerventionalist, I can go up through the blood vessels into the blood vessel that's blocked and either inject that clot buster directly into the clot, or I can take a little device up. We have a few different ones that are different and unique in their own ways, but by some mechanism go up and take that clot out and restore blood flow to that blood vessel. We can do that in people who can't get that clot buster medicine through the vein either because they didn't show up in time. So instead of having 3 or 4.5 hours for the medicine through the vein, we have 8 hours, and in a small subset of patients, up to 24 hours to go up into the blood vessel to mechanically remove that clot from the blood vessel. So we see a significant number of patients that aren't candidates for the clot buster medicine through their veins that we're able to help by going up and pulling the clot out directly. There are some tests that you have that when you get to the hospital that help us determine whether you can be a candidate for that. So oftentimes we do some specialized tests like CT angiography, which is a non-invasive test, or a test that just takes pictures but looks at the blood vessels. And we can also do MRIs, or we can do CT perfusions, which are actually CAT scans that let us see how blood is flowing to different parts of the brain. So a pretty complex scheme that we've developed with very good imaging equipment to now be able to tell who we think will benefit from these types of treatments. And as you can see, have a lot of treatments that we have to offer.
And I want to make sure that everybody understands. So gone are the days where maybe something couldn't be done for you if you were having a stroke. But I think the message the panel will say, do not go back to sleep. Do not sit on that couch. Do not wait. Go to the emergency room and get treatment of this. There's one more that Brenda brought up, and that was the aneurysm. So can you talk at all about how what that is, how somebody may present, and then that is your specialty.
That is one of my loves, brain aneurysms. So brain aneurysms, so we just spent 10 minutes, it probably seemed like an hour to you, with me talking about ischemic stroke. And from a population standpoint, ischemic stroke is the 4th leading cause of death in America. It is the leading cause of major morbidity and healthcare dollars in America today. And so from a population standpoint, it is something that everybody needs to be aware of and everybody needs to participate in helping to reduce. Brain aneurysms are a type of stroke that are completely different than ischemic stroke. Brain aneurysms are little blisters that pop off the side of a blood vessel in the brain that cause bleeding into and around the brain. It is also considered a stroke, but it's treated very differently than ischemic stroke. The workup is very different. The people who do this are oftentimes the same, but the treatments are very different. And brain aneurysms, we used to think were very uncommon, and when they ruptured, they commonly cause problems. Well, now we know they're actually pretty common. Maybe as many as 5% of adults on Earth are walking around with an aneurysm of some size somewhere in their brain. Now, only a small minority of those patients actually end up having problems from their brain aneurysms, and most of them live their life completely symptom-free. The problem is that the symptoms of a brain aneurysm are pretty sinister. They range from mild or severe headache to drowsiness to stroke to coma to death. It's classically described as the worst headache of your life, and patients give a very uniform description of this, of a thunderclap headache that comes on all of a sudden, the worst headache of their life. Typically, it's not a dilemma for them whether or not they need to come to the hospital because the pain is so bad that they either come to the hospital because they can't control the pain or because they lose consciousness or some other event happens. So brain aneurysm treatment is something that is a very fascinating topic and one that I won't bore you with if any of you are still awake out there. But it is something that is rapidly evolving, and we have very sophisticated methods for treating brain aneurysms, and we're seeing that recovery from patients with brain aneurysms is dramatically improving with the new technologies that we have to treat it.
Thanks, Dr. Gaughen. Now, Brenda, you work with Dr. Gaughen in the clinic, and so I said that you were actually a nurse practitioner,
Yes.
and some people might not understand what a nurse practitioner does, and particularly what you do in neurointerventional clinics. So can you just talk about that a little bit?
Well, another name for me is an advanced practice nurse. And so what that basically means is I am a registered nurse that has gone back to school to get advanced training, and I now have a graduate degree, otherwise known as a master's in nursing. And with that, I became a nurse practitioner. I had to sit for a special board exam. And many nurse practitioners are family, which is what I am, but there's other options as well. So there's like geriatrics, there's psychiatric nurse practitioners, there's also an adult or acute care nurse practitioners, there's also pediatrics. I chose family because I enjoy working with all age groups. I enjoy working with men and women. And then eventually I came to work with Dr. Gaughen. My background is primary care, which basically is, every disease process you can imagine and across the age span. So I dealt a lot with acute, which could be something as simple and as complicated as pneumonia, to chronic disease, which is what we talked about earlier, diabetes and hypertension. So from there, I've come to work with Dr. Gaughen because I am passionate about neurology, and I'm very excited about all the wonderful things that we are doing. So basically what my role is to basically see patients in the hospital and see patients in the clinic and help them with any needs that they may have, and also do referrals and get them with the right other providers. So many of our patients will need neurologists. Many of our patients don't even have PCP, so we need to establish that. Often our patients have a lot of emotional issues going through this traumatic experience. So I help connect them there as well.
All right, and we're going to...
She also does a very good job of reminding me that a patient is not just a brain on a stick.
That's correct. Those interpersonal
There are apparently
connections.
other organ systems, huh?
That's that interpersonal
The brain.
connection and bedside manner.
Yes.
So, I want to talk about, we talked about treatment, we talked about that for a little bit, and I just want the audience to really know that really if you have a stroke, we talked about, Dr. Gaughen talked about how many neurons you lose, but with the stroke, you could lose up to 1.2 billion neurons. And this put it in perspective for me. That accelerates your life by 36 years. So I was like, wow, I may have to stop lying about me being 26 if I had that happen. But if a patient can't get TPA, if they can't get interventional treatment, if they've waited beyond those 8 hours, we still have things that you can do to make sure that you're on the journey to make sure that a stroke is beatable. And that's what my passion is, I will say, is truly with rehab. And so I was a rehab nurse, and so Matt and Alison are going to share some of those things with us as well. So Matt, share your role of what a physical therapist does. And when they get involved, and there have been so many innovative things that have been done in rehab over the years, I know you would love to share that with us.
I would love to share that with you. So I think you said it pretty well. There's been a lot that's happened over the past probably 3 decades. So in the 1990s, back with the first George Bush, that was the decade of the brain, and during that decade we learned a great deal about recovery after a stroke, what exactly happened. Some of the things that Brenda and Dr. Gaughen just shared, those are things we started to learn about in the 1990s. Since then, really there's been this huge just increase in what we know about recovery after a stroke. So not just the medical treatment. So after John and Brenda save your life, then something has to happen after that. So hopefully we're good at helping to pick up the pieces and help encourage people to find a way to move forward. Really, right?
Yeah.
I mean, if you have a stroke, and particularly if you're not one of the fortunate folks who gets into the hospital in the right amount of time, you really have a very hard uphill battle, right? And so we see people that come to us that can't walk, can't talk, can't move their arm. So what we've done at Sheltering Arms, we really studied how do we do this? How do we help give people the best opportunity to make a full recovery, or at least as big a recovery as possible? I think the best way to describe it is that everybody that comes into the hospital to see us is at a fork in the road. So they've had something really terrible happen to them. And the fork in the road looks a little bit different for everybody, but it's the difference between returning to a life that is full of function and the types of things that we all love to do, right? So being, with our daughters on their birthdays. Sorry about that, by the way. Or just being able to get out to your community, your church, shopping, God forbid, or whatever it is that you like to do. You want to be able to do those things. Or it's really movement toward decreased function and maybe life in a wheelchair, life in an institution. So if we could do better, then we really should. So my passion is, I actually went back and studied to be a neuroclinical specialist, which is one of the half dozen ways that a physical therapist can be board certified. And I'm really passionate about creating the best breed of rehab here in Richmond so that people don't have to go to the Shepherd Center in Atlanta or Spalding Rehab Hospital in Boston or Craig Hospital in Colorado. Those are your best options, but not anymore. We have great options here. And so we've used very successfully some cutting edge technology, which we can probably talk about a little bit later as well, but things that you just don't find anywhere else on the East Coast all in one place. So we've got robotic walking retrainers that can help us get thousands or tens of thousands of repetitions to help neuroplastically change the way that the brain is wired. So while after a stroke you have tissue that dies, the rest of the tissue that's healthy and viable, we want to rewire that neural tissue so that it says, well, this activity of walking, this is still really important. So while I have to learn to do it differently, I can learn to do it in the same way. I just have to change my brain to allow that to happen, right? And a good example of that is, this happens all the time for all of us. So if you're an interventional radiologist, what you do with your hands it's very dexterous, right? So it takes a ton of practice and repetitions to do that. And so Dr. Gaughen's brain has literally changed to be able to do those really fine tasks that he has to do to help people get well. Same thing's true if you have a stroke. You need to learn how to walk again. And so the brain has to change and adapt. So if we can get a few repetitions in traditional rehab, right? If somebody is trying to walk and they have 4 therapists trying to help them walk, and we can take a half dozen stepping repetitions, and they might have a heart attack while they're trying to do it because it's so difficult, and they might fall because it's not safe. We have tools and technology and a thought process that can use robotics and body weight support systems to get thousands or tens of thousands of repetitions that are safe, that are effective, and give someone the very best opportunity to recover. So one of the things I definitely want to get across is it matters where you get rehab. So you need to make a really good choice. It matters where you go to get acute medical care. It matters the doctors that you see, and it certainly matters the rehab that you get. So if you have to drive a little extra to get to where you need to go, you need to do it, because you only get one shot at it.
So I want to talk about that. Callers, it's between 6:30 and 6:45. We'll be glad to take your calls. Please call us at 804-915-5202. I want to talk about that. We talked about preventable, treatable, and now we're talking about being beatable. And Matt brought up some great points that I want to talk about. And in all of that, you need to know you need to get to a stroke center, a primary stroke center fast. We talked about the neurons that are dying off, and I think that's important because stroke is the leading cause of disability. So Matt, when you talked about going to the right places, you still need to get there fast, because the decision of going to, and this is why I would like for you to break down, of an acute rehab to the next level of rehab, how is that made and what does that mean? And you really want to talk about rehab right away and how long you have for those things to come back.
Right, so you definitely need to get to an acute medical facility to get emergency care as fast as possible, like we've already talked about. You don't want to mess around with that. You need to go straight to the hospital if you have any concerns, if you have any suspicions that you might be having a stroke. And then it's also important to get early rehabilitation. So after you're done with the life-saving measures in an acute hospital, moving to the best rehab hospital option that you have to get care as quickly as possible. Ideally, you've saved brain tissue by getting to the emergency room quickly, and so when you get to rehab, there's more to work with. But honestly, the earlier that we can see someone, the better the results. If it's someone, we want to make sure that we get people to the right after acute medical hospitalization place. And so then there are different levels of care throughout the community. There are a lot of really good options. We want to make sure we get people to the right location. If you can handle some intensive work, then an inpatient rehab hospital, like what Sheltering Arms offers, is the very best option to be able to do that. We have 2 locations. We have one on the south side near Chesterfield, and one in Hanover County as well. And then we also operate outpatient clinics throughout the Richmond area to be able to care for people after that hospitalization.
So let me ask you, do I have to go, or if I'm in rehab, or if I'm in the hospital and I need rehab, can I go home and then come back, or does it matter? What are the stipulations with that?
Yeah, the typical path is that the physician from the acute medical hospital would make a decision where you would go, in conjunction with the rest of the team, considering what all of the options are. Typically, it happens from the acute medical hospital, and then it goes to the rehabilitation hospital or to a skilled nursing facility if you can't quite handle the intensity of an inpatient rehab hospital. If you're well enough to go home, that's wonderful, and a lot of good things can be done in the home with therapy at home. Sometimes that's not possible, and sometimes that's not we always, of course, want people to be safe and able to have the best option for a long-term recovery. So we don't just want to do the expedient thing, we want to do the wise thing. And so that's why it takes a team of medical professionals to help advise you. We work for you. When you come into the hospital, there's all of us on this panel, and everybody else that you meet works for you.
Okay. And then after the acute phase, then Alison, talk to us about recreational therapy, because we talked about this really being a life-changing event, having a stroke. You're functional, something happens, and it's devastating.
Right.
So
I think the most important thing to remember is that you can continue to have a quality of life. The devastation that you have from a stroke sometimes is really hard to imagine that life can go on. And as recreation therapists, what we try to do in the inpatient setting is introduce the patient to the fact that they can return to the activities that they enjoy doing. They can get back out in the community. And our role in that acute care is really to give them opportunities by taking them out into the community, introducing them to the challenges they may have and kind of problem solving with them, so they and their families feel comfortable with them returning to the community when they're discharged from the hospital. The next step is really looking at recreation and leisure and seeing how we can modify an activity that somebody enjoyed doing. So, for example, we have a lot of adaptive recreation equipment that we can use with folks. There's, fishing rod holders for someone that only has the use of one hand. We have a adapted golf program, and it's a paragolfer which raises someone to a standing position so they can golf from a standing position if they have mobility impairments that are causing them not to return to that activity. We really want people to understand that you can go through all this rehab. The physicians can save your life, and you can go through the physical rehab, but if you go home and you choose not to engage in life and you sit on the couch, all the progress and all the gain and all the work that you've done is just going nowhere. So teaching folks that they have these resources in the community, we have adaptive equipment for them. they need to continue to engage in physical activity. We're fortunate that we do have fitness, a therapeutic swimming pool, and fitness centers through Sheltering Arms. So we're open to the community for both on the prevention side. So all those things we talked about in staying active, we can help you with that. And then we also have those services available for folks that are having difficulty with their mobility or deficits from their stroke, that they can continue in our fitness programs to stay active and stay healthy. And that's the most important thing.
And I know you have a special program called Partners for Life.
Yes.
And if you want to share any
Yes.
of those examples, I think they're great.
Yeah, so our Partner for Life services at Sheltering Arms is just everything that's post-therapy. We have pools and fitness centers, personal training services that we do. We have certified therapists and fitness specialists that are really working with the neurologic population, kind of keeping them and maintaining their progress. We have a Club Rec program, which is a day recreation program specifically designed for those folks that have finished up rehab and are sitting at home in front of the television. So it's a comprehensive program that provides opportunities for them to get out in the community, to participate in an exercise program, to engage in social environment. The most important thing for quality of life is really keeping a social network and a support network, which is oftentimes lost after a catastrophic injury or illness. So our goal is really providing opportunities for those folks to continue to live life. We find ways for people to do things. We have an accessible travel program. We've taken several cruises. I've been parasailing with someone who was a stroke survivor. She was 89 years old. Had never even been out of the Richmond area, and she went parasailing. So I'm a firm believer that with adaptations and motivation and really, really understanding the value of staying active and engaged, that anything is really possible. Life does not need to end after you've had a stroke. We have a lot of tools that can help you maintain that activity level and quality of life.
I think that's great. And then Brenda, I'm going to come right back to you because I know you've started something very exciting as well for your program.
Yes, we started actually just last month. We launched it. It's the Aneurysm Support Group that is sponsored by the Joe Necro Foundation. And I totally agree with what Alison said. So much of what we do, even as team members, is provide a community for these people because it can be extremely stressful emotionally. So this Aneurysm Support Group, it's one of the only kind of its own in Central Virginia, the only other ones in Inova. So we are very proud of it at Secours, and currently we are meeting, our next meeting will be December the 16th, I have to throw a little plug in there, in room 156, St. Mary's Hospital. And then actually starting in January, we're going to be moving to the Reinhardt House, and from then on, it'll be every second Tuesday. So basically, this just allows aneurysm support people and also people who've also had AVMs and stroke to come together and meet people that also have similar concerns and issues. And so often what we find is that these people will actually kind of provide tools and strategies for each other, that they will also have some of the similar common issues. And they actually help each other a lot more than we as healthcare professionals can help them. So it's always interesting to watch that interaction. And the wonderful thing about the Joe Necro Foundation is it is started, or it was launched by Natalie Necro, whose father passed away from an aneurysm several years ago. And one of the nice things about the organization is every group that they have, and the majority of them are in the southern part of the United States, they facilitate it with a co-facilitator that is also an aneurysm survivor. So I actually have, my co-facilitator is Sharon Adams. I'm sure she wouldn't mind me saying her name. And she is my co-facilitator, is also an aneurysm survivor. So she knows firsthand what it's like to go through this process, and actually was very instrumental in getting us to start one here in Richmond.
Well, I have to say, just to sort of back up what Brenda is saying, is that this is the Joe Necro Foundation, the Brain Aneurysm Support Group, is a wonderful outlet for people that are trying to recover from brain aneurysms and hemorrhagic strokes. Because as a doctor, we can make you better. I can make you move your arms again and move your legs again, but there is such a strong psychological component, emotional component to the recovery from stroke of any kind, disease of any kind. And it's oftentimes underplayed because someone who otherwise seems like they're doing so well because they're able to move everything and talk the right way, it's hard to recognize some of these very deep psychological and emotional problems. Something like this support group lets people know that there are other people like them out there, and does give you the tools, I think, to help feel stronger about recovering from a disease like this. So I take my hats off to Sharon Adams and Brenda Sawyer for putting this together, because I think it's going to be a wonderful tool for the community.
Yeah, and some of the things that we're talking about, like the support group, definitely is free. Partners for Life, is there a cost to that at all?
There is, but we do work hard to keep the costs at a minimal for the community so people can access the services that we have. But it's cash-based services, but it's a minimal charge.
Okay, and I think you want to remember too, with the partners that we have with Bond Secours, Good Help to Those in Need, there may be some things that we can be able to do to help you to do that so that you can continue your journey. I wanted to talk about your neurointerventional radiologist, or it's a neurointerventional surgeon actually, but you build a rapport, I think, with your patients, and that you see them throughout, which is really good. So it's not just I do this diagnostic and then that's it. So I just want you to really explain what it is again that you do, and that how you follow up with your patients as well.
Well, I start assuming care of patients very early on, really when they arrive in the hospital. Probably the first physician that you'll see when you're in the hospital is an emergency physician. They are very adept, very skilled at being able to figure out what's wrong with patients very quickly. So we get the CAT scans, we get the imaging very quickly to figure out what's wrong with patients. When we identify a patient that is potentially either an ischemic stroke or a hemorrhagic stroke, someone who may benefit from the things that I can do, I'm brought in very quickly. And one of the things that I do is to look at the pictures and make decisions based on what the pictures say. And then I'm also able to perform some procedures that can fix some of the problems that we see. I also follow patients while they're in the hospital, take care of them in the hospital, help get them transitioned to the rehabilitation stage of their treatment. Then I follow them long term in the outpatient setting to make sure that they are improving. And it is remarkable to me how sick people seem when they're in the hospital, how sick people are when they're in the hospital, how close to death they come with some of these diseases, and with a strong attitude and rehabilitation, how wonderful they do in the long term. People walk into my clinic all the time that are 6 months, 12 months, 2 years out from strokes and brain aneurysms that I don't even recognize when they walk in my clinic, because they are so dramatically different than the person that I saw when they left the hospital. So I do have to emphasize that this is, and I tell all my patients this, that this is a disease that happens very quickly, regardless of whether it's an ischemic stroke, a hemorrhagic stroke. It happens very quickly, and the recovery from it is very slow. And patience on the part of the patient, on the part of the family, on the part of the caregivers is very important, because with the appropriate patience and a positive attitude, the recovery can be, although it can seem very slow, can be very dramatic. And I think with all of the things that we know about this disease process now, we can move people from a very, very sick place to a place where they're back doing things that they love to do. So it can be a very rewarding field. And am I allowed to talk about my collaborations?
Yeah, and then I'm going to go back to Matt. Yes.
Okay. Just to give my plug out there, I am also an assistant professor at the University of Virginia, and I think I'm very happy to be a part of what I find to be a fairly unique and I think a very advantageous collaboration, and that's a collaboration between the Bon Secours healthcare system and the University of Virginia healthcare system to provide neurointerventional specialty service to the Bon Secours system. And what we find is that these diseases, on a population basis, take a large number of people to be seen to really develop the skill set to treat these patients expertly, and that's most commonly seen in the academic center. And what we've done is we've brought that academic level of expertise with myself and my two partners, Lee Jensen and Avery Evans, to the Richmond area and the Bon Secours system. And this has been a collaboration that we've been doing now for over a year, just over a year, and I think has been very well received, and I think an overwhelmingly positive response.
It absolutely has. And Matt, I wanted to follow up with you as well. As you said, you really wanted to bring things to Richmond. So I think we're very fortunate with both of you in doing that. But I also want you to talk about a little bit about that. What makes it different? I mean, you've done some very innovative things. And then also share your other team members, because we may know physical therapy, but I know it's not just physical therapy that is there at Sheltering Arms.
Right. Yeah, you're right about that. So the physical therapists spend a lot of time thinking about how can we help somebody move better, how can we help them walk better, and that's great. But if you can walk to the refrigerator but you can't get a sandwich out of it, you're going to starve to death. So then the walking isn't very good, and it's not very useful. So we do have to think about the whole picture, and rehabilitation is about looking at the entire person, making sure that we're meeting all of their needs, addressing their unique goals. So we have occupational therapists that help think about the activities of daily living, the things that you need to be able to do to take care of yourself. Speech therapists that help with swallowing or being able to speak better. And then the physical therapists that I mentioned. There's also a broader rehabilitation team. We have rehabilitation nurses, which I know you have a special place in your heart for that, Pat. Mm-hmm. And then physical medicine and rehabilitation physicians as well. So at Sheltering Arms, we're really fortunate. We have more PM&R physicians than you can shake a stick at, which for an organization our size is a bit unusual. Mm-hmm. So we provide a very high level of care, which just in the industry is, like I said, it's unusual. It's costly way to do care, but we believe it's the right thing to do.
Hello, caller. Well, let me ask you this. So one of the big things that people want to know after having a stroke is driving. So I'm going to let any one of you, all of you could speak to that issue, and the buck probably stops with you. But I think that's something important.
It is important, and there are probably, and I don't know this as well as I probably should know, there are regulations at the DMV that don't allow you to drive, and I think that is, correct me if I'm wrong, I believe it's 6 months. And that's for anybody with a stroke, anybody with a seizure, and that's regardless of what deficit you have left over from it. And a lot of what outside of that, what you're going to be asked to do is going to relate to how badly you're injured from your stroke, how much you recover from your stroke, and how fast you recover from your stroke. And I always tell patients I'm not a police officer, so there probably are police officers that pay attention to this, but really the reason that we have that restriction on driving is because until you are healed from that, it is a safety risk for you and for the other people on the road, and so we do take it seriously.
Hello,
I don't know if you have
caller.
anything to say about that.
Hello, this is Delphine T. Watson, and I thank you for being on the TV. But I have a question about the aneurysm.
Okay.
My sister had an aneurysm. Do I got to see Dr. Gaughen and get tested for an aneurysm?
Okay. Thank you, caller.
Mm-hmm.
That's a very good question.
That is, and we have like 2 minutes.
And that's and unfortunately this may get abbreviated. But the short answer to that is if you just have one sister, we don't currently recommend screening of other family members. There is a recommendation out that says that if you have 2 first-degree relatives with a brain aneurysm or a ruptured brain aneurysm, that you should undergo screening. And so that's a brother and a sister, a brother and a parent. So the hard and fast answer to that is if you need 2 first-degree family members before we strongly recommend it. That being said, screening is non-invasive. It doesn't put you in harm's way in any way. It doesn't take radiation. It doesn't take iodinated contrast. It doesn't take any risk of a procedure other than just the time to take the test. So I actually have a very low threshold for screening family members of patients with aneurysms, particularly ruptured aneurysms, because we know that people who have aneurysms and family members with ruptured aneurysms have a higher risk of their aneurysm rupturing. So certainly if you have a family member that has had a brain aneurysm, particularly a first-degree relative, a sibling or a parent or a child, and you are concerned about it, I would encourage you to seek the advice of a specialist, a neurointerventionalist or a neurosurgeon about what your options are from a screening standpoint.
Okay. So I think that's great advice. One thing I want to tell everybody is that you can certainly call or come to our website, Secours, look for Neurosciences. You can Google that, and all our panel will be there, and this show will be repeated for you. If you have further questions, we can also help you with that as well. We shared with you today the stroke is really preventable, treatable, and beatable. We do not want you to give up hope on if you are having signs and symptoms of a stroke, or if you've had family history of someone having a stroke. That doesn't mean that you will have a stroke. So as you prepare next week for Thanksgiving, we want you to remember your blessings. Remember some of the things that we shared with you on prevention, and share with your family members and friends the signs and symptoms of stroke, and certainly share that you too can beat stroke. Our next show will be December the 3rd, and we'll be discussing brain tumors and the Cullister Center, a special treasure also in the RVA. Until December 3rd, have a great neuroscience week.
Be sure to have your pets spayed and neutered.